Welcome to today's webinar, Hepatitis A Vaccination Among People Experiencing Homelessness. I'm Caroline Gumpenberger, and I'll be the moderator for the webinar presented by the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration and the Bureau of Primary Health Care. This is a 60-minute presentation with the last 15 minutes reserved for Q&A. There's a chat box below the presentation slides for participant questions and technical issues. Please type your questions or technical issues into the chat box at any time during the presentation. A select number of questions will be answered at the end of the presentation during the Q&A session. Remaining questions will be logged and provided to the presenters for written responses after the webinar. If you're having technical issues, you may also call Cecilia Teichert at the Council's office at 615-226-2292, extension 241 for assistance. Our presenters today are Noele Nelson, Acting Branch Chief, Prevention Branch, Division of Viral Hepatitis, and Cynthia Jorgensen, Team Lead, Communication, Education, and Training, Division of Viral Hepatitis. Thank you, and now I'll pass it over to Noele.
Thank you, and good afternoon. Today's presentation will describe the current Advisory Committee on Immunization Practices recommendations for use of hepatitis A vaccines among persons experiencing homelessness. We'll also discuss assessing the clinical and public health implications of current Advisory Committee on Immunization Practices recommendations for use of hepatitis A vaccines among persons experiencing homelessness. We'll also describe and talk about communications materials targeting persons experiencing homelessness. The outline of the presentation will be a brief introduction of hepatitis A, overview of the recent hepatitis A outbreaks, discussion of the ACIP recommendations for persons experiencing homelessness, and then Dr. Jorgensen will discuss communications materials. I will start with a brief overview of hepatitis A virus. Hepatitis A virus is a single-stranded RNA virus member of the picornavirius family that replicates in the liver and then is excreted in bile and then stool. Illness from hepatitis A is typically acute and self-limited. Clinical symptoms are indistinguishable from any other viral hepatitis or other infectious or non-infectious causes of hepatitis. The average incubation is 28 days, but ranges from 15 to 50 days. An infected person can excrete virus in stool for up to 2 weeks prior to becoming symptomatic, making identification of exposures and initial detection of outbreaks particularly difficult. Person-to-person transmission of hepatitis A occurs through the fecal-oral route, such as close personal contact with an infected household member or sex partner. Common source outbreaks and sporadic cases occur from exposure to fecally contaminated food or water. For example, uncooked hepatitis A virus contaminated foods or inadequately cooked food, or food can be contaminated after cooking. Waterborne outbreaks are infrequent in developed countries such as the U.S. with well-maintained sanitation and water supplies, and we have not seen a waterborne outbreak in the U.S. in many years. Little is known about hepatitis A virus immunity, whether through vaccination or natural disease, among homeless populations in the United States. While homelessness has been linked to hepatitis A outbreaks in the past, it has only recently been considered an independent risk factor for infection, as many individuals may have other known risk factors, such as substance use or underlying liver disease. The seroprevalence studies of immunity in this population that have been done found a higher than expected level of immunity with older age, duration of homelessness, and injection drug use as significant predictors of being immune to hepatitis A infection. Now I will give a brief overview of the ongoing hepatitis A outbreaks in the United States. Prior to July 2016, there hadn't been a large multi-state hepatitis A outbreak in the United States since the 2013 outbreak associated with frozen pomegranate arrows. And there hadn't been a large person-to-person community-wide outbreak since 2003. Two outbreaks associated with contaminated food items imported from hepatitis A virus endemic countries occurred, followed by community-wide person-to-person outbreaks that continue to this day. At present, there are over 14,000 outbreak cases have been reported, with the Division of Viral Hepatitis Laboratory sequencing over 4,500 specimens. Hepatitis A incidence rates have increased dramatically in the wake of the outbreaks. In 2015, during a non-outbreak year, the national hepatitis A incidence rate was 0.4 per 100,000 population. In 2015, state hepatitis A incidence rates ranged from 0.67 per 100,000 population in Mississippi to 0.79 per 100,000 population in Arizona. Based on preliminary data, the national hepatitis A incidence rate increased to 3.8 per 100,000 population during 2018. The increased incidence rates are even more dramatic when compared at the state level. In 2018, state hepatitis A incidence rates ranged from 0 per 100,000 population in Alabama, Montana, and North Dakota to 111.92 per 100,000 population in West Virginia. Here is the latest national epi curve. Due to reporting lag and the relatively long incubation period of the virus, the far right of the curve is subject to change. This curve was created with data from the National Notifiable Diseases Surveillance System, which relies on complete and timely reporting from states. This slide shows hepatitis A outbreak case counts that are publicly available on state websites as of May 3rd, 2019. About 16,500 cases, 9,400 hospitalizations, and 170 deaths have been identified. The hospitalization rate is over 50%. Only some of the outbreak-associated states report cases among persons experiencing homelessness on their websites. Among 8 states, over 900 cases are reported publicly, which is substantial, considering that states with known high numbers of persons experiencing homelessness, such as California, whose outbreak has already ended, had a high number of cases. Now I will talk about the hepatitis A vaccine's ACIP recommendations. Before I do that, I want to ask a poll question. For the providers who are on the call, do you routinely administer hepatitis A vaccine to persons experiencing homelessness? Take a minute to give you time to answer. Okay, it looks like some of you have answered. And clearly, about 75% of you looks like are routinely administering hepatitis A vaccine. So that's great. So now I'm going to give an overview of the vaccines, and by the end I want to help us to understand how we can increase routine administration of hepatitis A above 75%, but also help facilitate vaccination among providers who are already vaccinating. So the hepatitis A vaccines in the United States are all inactivated killed virus. The monovalent vaccines are Vactor by Merck and Havrix for GSK, and then combination vaccine, which includes recombinant hepatitis B surface antigen, as well as hepatitis A strain, Twinrix. Vaccine is administered on a 2-dose schedule and was first recommended by the Advisory Committee on Immunization Practices in 1996. Twinrix, however, is administered on a 3-dose schedule with accelerating dosing available. However, a 12-month booster dose is required with accelerated dosing. And the immunization schedules can all be found on the CDC website. The hepatitis A vaccines are highly immunogenic and safe. The hepatitis A vaccines have greater than 95% immunogenicity among immunocompetent adults who develop protective antibodies within 4 weeks of receipt of 1 dose. Detectable antibodies persist for at least 20 years after hepatitis A vaccination in childhood, and antibodies persist for an estimated 40 years or longer based on modeling and antibody to hepatitis A viral kinetic studies. Although recommended as a 2-dose series for monovalent vaccine, evidence of protection for up to 11 years exists for 1 dose of single antigen vaccine. And clinical and outbreak response experience suggests that lifelong protection is possible after 1 dose, meaning that we rarely see vaccine failures, even in outbreak situations. The recommendation for routine use of hepatitis A vaccine were last published in 2006 with updates over the years since then. Currently, the vaccine is recommended for all children at age 12 to 23 months with a permissive catch-up vaccine. Vaccine is also recommended for travelers, people who anticipate close contact with international adoptee, men who have sex with men, users of injection and non-injection drugs, persons with chronic liver disease, persons with clotting factor disorders, and persons who work with hepatitis A viral infected primates or with hepatitis A virus in a research laboratory setting, and anyone wishing to obtain immunity. In February 2019, vaccine has also been recommended for persons experiencing homelessness. And this is the exact language of the recommendation in the ACIP policy note. All persons aged 1 year and older experiencing homelessness should be routinely immunized against hepatitis A. Routine vaccination consists of a 2-dose schedule or a 3-dose schedule when combined hepatitis A and B vaccine is administered. So, congregant living conditions, both within and outside shelters, increase the risk for disease transmission, which can result in outbreaks. The systematic literature review that was done for the ACIP policy note concluded that there are substantial benefits of vaccinating persons experiencing homelessness, and that the cost and risk of vaccinating persons experiencing homelessness is much lower than the risk of not vaccinating. Some clinical considerations also accompany the ACIP policy note. Concern about loss to follow-up before hepatitis A vaccine series completion should not be a deterrent to initiating the vaccine series in persons experiencing homelessness. 1 dose of hepatitis A vaccine provides personal protection and can contribute to herd immunity, although long-term protection might be suboptimal. Also, the hepatitis A vaccine series does not have to be restarted if there's a long lag between the first and second dose. The second dose can be given at any time. So the advantages of hepatitis A for persons experiencing homelessness include that persons experiencing homelessness might have difficulty implementing routine recommended non-vaccine strategies to protect themselves from exposure, such as using clean toilets, regular hand washing, or avoiding crowded living conditions. So therefore, vaccine is the most reliable protection from infection. Vaccination will provide individual protection and increase herd immunity over time, reducing the risk of person-to-person outbreaks. And routine hepatitis A vaccination of persons experiencing homelessness allows for administration of vaccine in facilities that already provide healthcare services for the homeless population. So due to limited access to healthcare and historically low rates of insurance coverage, the majority of adults who experience homelessness have low rates of immunization coverage overall, with vaccines routinely recommended for adults. So community health centers provide preventive and primary health services to meet the specific needs of persons experiencing homelessness, including vaccination. And then street or shelter-based vaccination is also very helpful during outbreaks for administering vaccine. 36 states and the District of Columbia have extended Medicaid under the Affordable Care Act, which provides an increase in coverage and access to care among persons experiencing homelessness. According to the National Healthcare for the Homeless Council report from 2017, an estimated 77% of persons experiencing homelessness had access to some form of insurance. So that brings me to poll question 2. What are the challenges of administering hepatitis A vaccine to persons experiencing homelessness? I'll just give you a minute to answer this question. Okay, I see a lot of great answers that came in, and that's really will be a great start to a discussion. Thank you. We'll move on to the next question. So question 3. What can CDC do to assist with overcoming barriers to hepatitis A vaccine among persons experiencing homelessness? I'll just read it again because I don't see answers coming in yet. What can CDC do to assist with overcoming barriers to hepatitis A vaccine implementation among persons experiencing homelessness? Okay, this is really great. A lot of very helpful answers that I can see on my side. Okay. So I guess one other thing that I would like to mention is that so Twinrix is a really good option for persons that have risk for both hepatitis A and B. However, it should not be used for post-exposure prophylaxis, only for routine vaccination. But when some of you mentioned in the answers to the questions, which we can get back to later, about issues with supply in clinic. So it'd be really helpful for us to know if it's single antigen, monovalent vaccine, or combination vaccine that is the issue. So at that point, I'm going to turn over the presentation to Dr. Cynthia Jorgensen, who can talk to you about some of the communications materials that we have. And then afterwards, I'm certainly happy to answer any questions about the vaccine recommendations, but also talk more about your answers to poll question 2 and 3. Thank you.
Thank you, Dr. Nelson. So my part is going over some of the education and communication materials we have to support your work. We have a series of education communication materials directed for both the public and the professionals. For the public, we have a series of fact sheets. There's a 2-page fact sheet that's a little bit more involved, a 1-page that is very simple and very designed for people with low literacy. We have posters, and then we also have pocket cards. All of these materials can be localized with your specific information. The pocket card, one is designed to say, here's where you can go get vaccinated. The other lists the symptoms of hepatitis A, and you can put in a place where someone could seek medical care. For our professionals, we have our website that has a lot of information on the outbreak in general. We have posters for clinicians, flyers, and then we're in the process of finalizing a vaccine hesitancy guide. This is for people who are experiencing individuals who don't want to get vaccinated, and we've tried to provide phrases and things that you could say to encourage them to get vaccinated. All of these materials are available at the website that you can see on the slide right now. We do have materials that are specifically targeting people experiencing homelessness. So there's a 1-page fact sheet and then posters that specifically mention homelessness. We have posters that are targeted for people who use drugs, men who have sex with men, and then we have one poster that has all of those populations on it. So we're hopeful that if you don't want to do homeless specific, you can use one of the posters that says here are the individuals that need to get vaccinated. We also are real interested in hearing from you if there's something that you would like us to develop. I'm sure you're not alone in that request. So in addition to the questions you might have for Dr. Nelson, please feel free to either email us, chat, or provide feedback on materials that we can develop to help you guys do your job. And with that, I think this concludes our part of the presentation, and we'll be opening it up now for questions.
Great. Thank you so much, Noelle and Cynthia, for that great information. For the participants today, if you would please enter any questions you might have into the chat box. We'll try to get to those as many as we can today. The first question that we have comes from Lori, and the question is, does Medicaid or Medi-Cal in California pay for the immunization?
So this is Noelle. So I'm not sure specifically about each state Medicaid system. I can certainly look into that and get back to you.
Great, thank you. I also see a few questions on the efficacy of Twinrix. If there's any information that you might want to offer on the caveat of 1 dose of Twinrix not providing protection?
Sure, that's a great question, and yeah, really important. So thank you for those that brought that up. So for hepatitis A, one dose of Twinrix give you over 90% protection. So for hepatitis A, Twinrix is certainly a very good option in an outbreak. It would only give you about 30% protection or less for hepatitis B. 2 doses of Twinrix will give you about 80% protection for hepatitis B, but really the complete Twinrix series is needed for full protection against hepatitis B. So when using Twinrix, it's really important to try to administer at least 2 doses to get that hepatitis B protection. Of course, any protection is better than not vaccinating. Similar to the recommendation for the monovalent for hepatitis, for the monovalent vaccine to at least give the 1 dose. But certainly best use of Twinrix for hepatitis B coverage is to give 2 or more doses.
Great, thank you, Noelle. I see another question coming in from Bonnie, who is asking for information about clients experiencing homelessness and experiencing mental illness. Bonnie, for resources on this population, we do have some materials posted on the Council's website. We would be happy to post that for you. I would also like to post this to Noelle and Cynthia to see if they have any information that they would like to speak to with any co-occurring morbidities.
I don't believe that we have specific information on our website. Correct me if I'm wrong, Cynthia, for homeless suffering from mental illness, but I could probably point you to some materials, maybe from SAMHSA or other organizations.
Yeah, we don't have anything that addresses the mental illness and homelessness. If there's a particular something that you need, let us know, because I'm sure you're not the only one who has that need.
Great, thank you so much. Our next question comes from Sarah, and she asks, what are some creative ways that healthcare professionals have immunized a community of homeless individuals, such as in a homeless shelter?
So this is Noelle. So in California, where the outbreaks really started and came to light that there was a real issue with hepatitis A among persons experiencing homelessness, there was a real effort to go out on foot teams into the shelters and vaccinate. So the experience from the people that I've talked to that were part of these groups really had to go back multiple times, really try to establish a rapport, education, not a simple activity. But I would say that foot teams have been one of the best ways during these outbreaks to go out and reach particularly the non-sheltered persons experiencing homelessness. And I don't know if Mark Wang on the call has anything to add to that.
Hey, thanks, Noelle. Yeah, this is Mark. I'm on Noelle's team at CDC. Some of the things we've heard from other states are using these peer educators. I noticed folks had kind of entered the free text about misinformation and distrust of government or healthcare system. So that's something that we've heard has been effective, using the existing staff at those shelters, at those food pantries, at those facilities, that the homeless persons experiencing homelessness may see day in and day out and have developed rapport. So say, for instance, sometimes if a vaccination team comes in from out of town, there may be some that are hesitant to receive vaccination, but on the 3rd or 4th visit, they get to know them and the vaccinators and develop some sort of rapport, and the vaccination can be a little more successful. Thanks.
Great, thank you, Noelle and Mark. The next question comes from Mary, and she asks, is the CDC recommending vaccinations for all people experiencing homelessness who are over the age of 1 year, even in states that are not highlighted on slide 13?
Yes, this is Noelle. Yes, the CDC ACIP recommends vaccination of all persons experiencing homelessness routinely across the country. When hepatitis A vaccine was first introduced in 1996, it was recommended just in western states. It was an incremental recommendation based on the incidence and was primarily focused on the western states. The recommendations since 2006 have been routine for the entire nation.
Great, thank you, Noelle. Our next question comes from Jennifer, and she asks if you have any reports or experience of working with EMS or community paramedic programs to vaccinate people experiencing homelessness.
So there have been, and each state does it a little differently. There's been experience from West Virginia, Kentucky, and some other states, but I can't speak to the specifics of that. Maybe Dr. Wang?
That's something that we've been encouraging states to do, but as Noelle alluded to, it sometimes is very location specific. It's a good idea. You could use some resources, but I think my understanding is that there's certain laws that are very kind of state or local county specific. One aspect of that question is sometimes if a state or location has declared a public health emergency or declared an outbreak, then that may have impact on the legal ramifications of having a EMS or community paramedic deliver the vaccinations. Also, these of other nurse vaccinators and physician extenders. But I don't profess to be an expert in this kind of legal arena. I'll just say that it is state to state that we've seen. Thanks.
Great, thank you. Our next question comes from Libby, and she asks, does the CDC have plans to fund states to increase vaccination efforts to prevent outbreaks in at-risk populations?
So this is Noelle. So we have provided some funding to the states that have declared outbreaks, who have submitted applications for funding. So there has been limited resources available. So there's a number of means by which states can request funding for vaccination. They can request funds via 317 for outbreaks, and then there have been other mechanisms. If you're from a state where you're seeing an increase in hepatitis A cases and you're having a problem obtaining vaccine for funding reasons, I encourage you to reach out to us, and we can help point you to potential opportunities for additional resources.
Great, thank you so much. And it looks like that is all the questions that we've had submitted today. If there are any final questions, please feel free to submit them to us, and we'll submit them to the presenters. And it looks like we just got one. We have some information from Amy that I'll post to the group. It's been very helpful. Thank you, Amy. So that looks like that's all of our questions for today. Thank you, everyone, for presenting. Thank you, Noelle, Cynthia, and Mark for being available to answer questions. And thank you for all who joined today's webinars. Presentation materials and a link of the archived webinar will be available on our website, www.nhchc.org, within 3 business days. A survey for evaluating today's presentation will open in your browser at the end of this session. We appreciate your time today, and thank you again, and the webinar is now closed.